So we're going to look at hypothetic abduction and differential diagnosis and their relationship to each other. We're going to use a very simple condition again, which is lateral elbow pain. So we look at the first usable symptom, in this case lateral elbow pain, in order to generate a hypothesis. Now, given this, we're looking at lateral elbow pain, it's better to do this than go into differential diagnosis. So here we go. We generate a hypothesis, H1, and we compare that with the patient's symptoms, or another way of putting it is the hypothesis is attacked by the patient's signs and symptoms to see how good a fit it's going to be. Now, if this fits, we have a provisional diagnosis that can then be again attacked with bias and error mitigation, and if it withstands that attack, then we have a provisional, a provisional diagnosis that could be moved to a working diagnosis stage of generating a treatment plan and prognosis. If there's a misfit, then we can either generate H2, a second hypothesis based on the signs and symptoms the patient's given us, or we can move towards differential diagnosis, which is what we shall do in this particular presentation. Generally though, with differential diagnosis is when you come across a symptom that can have multiple equally plausible or nearly equally plausible causes, and you don't want to go through the positive vetting of each of those potential diagnoses. All right, so here we are. This is our first symptom, non-traumatic lateral elbow pain. So we generate H1. We're going to go into hypothetic abduction because the chances are this is going to end up being a common extensive tendinosis or tennis elbow, or incorrectly called, seriously incorrectly called lateral epicondylitis. So we look at the focus illness script or the essential illness script of the patients, of how the patient describes their signs and symptoms, and we see how they compare to each other. So if they compare well and it fits, we have a provisional diagnosis where we use bias and error mitigation, which is mostly about differential diagnosis. With some other stuff, we'll talk more about that when we look at bias and error correction, but it's mostly differential diagnosis. And that increased look may end up modifying this diagnosis, so it's no longer a tendinosis, but it becomes a tendinitis. The difference being that the signs and symptoms of tendinosis are much, much, much less acute than that of tendinitis. Or the bias and error mitigation, the level of mitigation may not be acceptable, or it may be acceptable, and we have a diagnosis without any modification whatsoever. Now, if this misfits, that is, the patient's signs and symptoms don't fit our hypothesis, then, or if the bias and error mitigation, the levels of it is unacceptable, then we have to either generate H2 or we go into exclusionary diagnosis, differential diagnosis. If we generate H2, we'll say it's biomechanical dysfunction, and then we go through the whole process. And we keep doing that until we come that does fit the patient's signs and symptoms. On the other hand, if we're going to go to exclusionary differential diagnosis, these may be them. Biomechanical dysfunction of the elbow, arthritis or arthrosis, a degenerative ligament tear of the lateral collateral ligament, or it could have been a tendinitis, which we should have picked up here anyway. So let's look at this from the perspective of starting with differential diagnosis. So we have non-traumatic lateral elbow pain. We're going to go into exclusionary differential diagnosis because inclusionary is just too much work. Our differentials are common extensive tendinosis, arthritis or arthrosis, biomechanical dysfunction, degenerative lateral collateral ligament tear, or a common extensive tendinitis. There is a possibility this is referred, in which case all of the local signs and symptoms will be absent. So we do our exclusionary testing now. And these are very, very sensitive tests for each one of these. So for a tendinitis, if the tendon isn't tender, then you don't have a tendinopathy. If the quadrant tests are negative, then you don't have an arthritis or an arthrosis. And also, you won't have a biomechanical dysfunction. Now, these can be differentiated by the pattern of the quadrant screwing up. But if they're completely negative, then it cannot be an articular problem, is basically what we're saying. For degenerative lateral collateral ligaments here, if the lateral collateral ligament is not tender to palpation, that's not what it is. And if it's not a tendinitis, then the tendon may be tender, but not exquisitely tender that you would have with tendinitis. The survivor of this, the one that shows positive here that can't be excluded, is the one we go on to. So we'll say it's because the surviving condition is because the common extensor tendon is tender, but it's not exquisitely tender. So we move into hypothetic abduction now, with the hypothesis being common extensor tendinitis. We then attack it with bias and error mitigation. If these levels are acceptable, we now have a diagnosis. If they're unacceptable, then we have to review the exam and get a second opinion if necessary. Now, what's interesting is that the bias and error mitigation process has been reduced. And it's been reduced because bias and error mitigation is mostly about, not entirely, but mostly about differential diagnosis. And we've already done this up here. So what we have is a system that looks complicated if we go through hypothetic abduction and take it into the differential diagnosis. But if you reserve hypothetic abduction for conditions that have few possible causes, plausible causes, and differential diagnosis for those conditions that have multiple plausible causes, you won't find that they look odd. There isn't any real problem in selecting which one you want. Finally, about deductive clinical reasoning. Now, as we said, deduction is binary. It's either absolutely true or it's absolutely false. There's no grayness here. Whereas all the inferential reasoning we do is probabilistic. It may be pretty close to being certain, say 99% probable on really good cases, or 1% probable. That means it's 99% unlikely to be that condition, but it's always probabilistic. Now, the problem with deductive reasoning, it is binary. If you see these symptoms, you know that condition is present, these signs rather, you know that condition is present, but the question is that relevant to the patient's complaint? For example, Wilson's disease will give you these copper rings around the iris, so they have copper poisoning. But if they're coming in with lateral aorta pain, it's got nothing to do with anything. More to the point though, things like TOFI. TOFI can be extremely indicative of gout, but the gout has to have uric acid crystals, not calcium nitrate crystals, I think it is. Anyway, the biopsy will show you whether this is true TOFI or not. But it takes to another point, because you know the person has gout, it doesn't mean to say that gout is the cause of the patient's symptoms, or is even contributing to the symptoms or an etiology of those symptoms. So while deductive pathognomonic signs are deductive, that is, they are not probabilistic, they may not be relevant. So don't get caught up in the fact that you've got some really good signs.